However, I do have some declarations and disclosures for the center. We serve as a membership organization, and we do, in some cases, provide fees-based training programs. Some of those will be offered in the future. These are free and will be able to be retrieved and shared liberally with those of you that so choose to do that. We also provide advanced care planning materials to individuals and organizations, both on a complementary and a fee-based basis. So we have that available for you to share as well. Most of the information that we have in terms of our advanced care planning materials are available for download for individuals. We do ask, if you're representing an organization, that you purchase them in bulk for the nominal fees that we have established on our website. And then finally, we also serve, the center also serves as the National Pulsed Paradigm Program representative for both states of Kansas and Missouri. We are the only bi-state initiative in the country at the current time. And we serve as the leadership group that coordinates with the National Pulsed Paradigm Task Force in making sure that we comply with all the rules and regulations associated with the National Pulsed Paradigm Program. We are in the process right now of receiving, moving from our developing status to endorsed status, and we should be able to have that designation within the next 2 weeks for those of you that are interested in following those credentials on the website for the National Pulse Paradigm. In order for you to ask questions or to raise issues that you would like addressed by any of the speakers today, we're going to be having you listen to Matthew for a little bit in terms of how to navigate your screen and ask any questions that you may have. So Matthew, you want to take it from here?
All right. Hi guys, thanks for joining us today. And I think some of you probably were on for some of our past webinars, but I'll go through the basics once more. This Zoom platform has a little toolbar at the bottom, and down there you'll see a Q&A button. Depending on your interface, it may jump up to the top. So just look for the toolbar. And if you use the Q&A button and open it up, you can submit questions there. And if you submit questions in that field, we'll see them pop up, and then we'll be able to answer them as a part of the presentation. Some of them I'll just answer in text on my own. I'll just be kind of in the background during this presentation, and some of them will be asked, or technical questions will be answered by our panelists. So outside of that, you can always just use the chat function if you want to send me a message, have any questions about the platform, or having any technical difficulties, let me know, and I'll do my best to get you up and running. So thanks very much.
Okay, so as I mentioned, this session and the others, ones that come in December and the one previously in November, are recorded and archived and will be available on our YouTube channel. If you wish to access that information and are unfamiliar with navigating the website, in order for you to be able to do that, just simply send Matthew an email. His email appears there on the screen right now, and he'll be able to give you some information on how to do that. Also, I provided you his phone number if you've got questions and would like to be able to have this information that's available to you in either shortened format or modified format, as long as you're using the information and acknowledging and attributing the presentation to the work of the Kansas-Missouri TPOPP Task Force. We'll be fine with that. So let's begin. I'll try to spend about the next 40 minutes or so talking about advanced directives and advanced care planning and the importance of it. Maybe in also talking a little bit about the forms and kind of the legal issues that we all have to be cognizant of as we work with families related to both advanced directives and physician order sets as they progress in disease and frailty, and then matching up those disease progressions with their goals of care. So back in the 70s really is when advanced care planning got started in this country, and the uptake was first pretty promising. We went from about 0 to 15 very, very quickly in a range of very few short years, but then it kind of languished at that point and really didn't do anything for about 15 years. And then finally it bumped up to 30% in the mid to early 2000s, mainly because there were significant efforts at play in long-term care settings in being able to get long-term care residents, especially those that were facing debility and frailty signing up for advanced care planning instruments. And in many cases, it became a requirement of admission in terms of making sure that the advanced care planning documents were on file and that kind of thing, which is not a bad process or routine procedure to have in place. But despite its overwhelming support by consumers, and the legal arguments have not played well with the general public over time. And so in the late 2000s, Congress commissioned a report on advanced care planning that was broader than advanced directives. It's like, why do we think it's important, and what are we doing about it? And what we found out was that many people felt caught in the process. They really didn't initiate their documents because they were fearful of what might happen if they basically said they did or didn't want treatments, and then there came an episode in which they were faced with having to make those decisions, couldn't for themselves, and were worried about being caught by their documents. And that wasn't particularly unfounded in terms of some of those fears and anxieties. So if you had to take a look at what % of deaths are preceded regarding questions around somebody else making a decision for you, especially related to withdrawing and withholding of life-sustaining treatment, there's a kind of a query out there that we've used on a number of different venues to ask people what they think the chances are of them having to have somebody speak for them rather than being able to do it on their own. So kind of this just-in-time, I'll be able to get ready and I'll be able to know the answer to that question, and so will my surrogates in being able to do that. And what we found out is that more than 80% of us will be faced with a situation, because most of us will be dying very long deaths, if you will, in terms of chronic disease and debility over many, many years. And so 80% of us will actually have situations where others will be making decisions on our behalf. So how common are those limited treatment plans then at the end of life? So about every year, 2.4, 2.5 million people in the United States die. 2.1 million of those deaths occur in under some kind of healthcare situation. And these deaths, that 2.1 excludes homicides and car accidents. These are kind of not necessarily anticipated deaths, but certainly related to health issues and conditions. And 1.8 million of those deaths include a decision to withhold or withdraw life-sustaining treatment. So this is a big, big issue in American healthcare. 85% of us will die of a chronic condition over time. That's way, way up from the mid-50s and 60s when we were still dying in many situations of, acute episodes, heart attacks, and those kind of things. But many of the diseases that used to take our lives very suddenly have now developed into long-term chronic conditions, which make it much more difficult for families to have these conversations, mainly because we don't engage them in how sick their loved one is, or the patient, him or herself, in recognizing that. And we also don't do a very good job of bringing up that conversation as clinical practitioners in dealing with the families. We're not prepared, and hopefully we're going to be able to, through these series of workshops, help you feel better prepared in being able to have these conversations, especially for those that are living with limited life expectancies. There's also some concern, basically an overwrought concern, that the court was going to get involved and we're going to have legal risks associated with being able to make these kinds of decisions, which has really not been true. And so there have been very, very few cases in which the decisions by individuals, practitioners in acute care settings that made recommendations related to care have really affected families in any kind of negative way. What we do know about the moral and legal consensus around choices about end of life in supporting treatments is that we all have a right, and this came about through the new Cruzan case, that all of us have a right to refuse any medical treatment, regardless of whether we are terminal or curable, if you will. So that is a constitutional right that was established by the Supreme Court decision of Cruzan. We also know, theoretically, in our heads, that there's actually no difference between stopping an ineffective treatment or starting a treatment that we want to try for a limited trial. We know theoretically that it doesn't matter if the treatment doesn't work. we shouldn't have any qualms about stopping it. What we know to be true in many, many interviews in the research that's been done on beginning and ending of life-sustaining treatment is that there's a significant visceral reaction of the family or the deciding individual, the patient representative who's making the decision. If the patient, him or herself, is not able to, which is 80% of us, as I mentioned earlier, is that there's a great reluctance on the part of that individual to undo a decision that has been made, mainly because there's this sense that they have that even though theoretically there's no ethical problem, there's this sense that they are limiting the life of the individual or causing the patient's death in some untoward fashion. So it's whether or not we believe it to be theoretically neutral, we know that it actually affects people significantly when it comes time to make the decision. So it's another reason for us to get better at this and really be able to engage families in these kinds of conversations. We also know that decisionally incapable patients, don't lose the right to have treatment decisions made for them. So simply because an individual has shared their beliefs and their convictions with a family member, and they've not done a particularly good job of writing it down, that doesn't mean that that individual who is speaking for them, especially in states where there is no surrogacy law, which is true in Kansas and Missouri, they don't lose the right for those individuals to be able to speak on their behalf. That also was enshrined in the Cruzan case when the state said, you know, they had the right, and the Supreme Court made the decision that the states had the right to provide a standard that the individual had to meet. And clear and convincing evidence was the standard that was set in the state of Missouri. And following the decision by the Supreme Court that Nancy's family did not have the right to make that decision because there was no clear and convincing evidence in the state's, the Missouri state's protection of the individual at risk, the patient at risk, they had to find clear and convincing evidence, which they were able to do shortly after the Supreme Court decision was made, and then the state backed down and allowed the patient to make the decision. And the final thing is, there's a lot of consensus now that's growing out about tube feedings as a matter of life-sustaining treatment in terms of their effectiveness, especially for those with certain kinds of conditions and illnesses, especially those when the patient is dealing with dementia and cognitive impairment in terms of long-term. So I want to talk a little bit now about kind of the medical psychology around these kinds of things. And these references to physicians are shared by clinicians in general. So these apply to advanced practice nurses and PAs and other folks. This is not just simply targeting physicians for this group. But many of us are not prepared in our training as professionals to deal with patients around these kind of uncomfortable issues that basically touch on death. And we're less likely to effectively work with team members for end-of-life care because of that. If we're reluctant and we're anxious about it and nervous about it, we're less likely to call on other team members ourselves to do that. And we need to get better at it in terms of our own comfort levels and rely on those that have the skills to be able to do this. And as a result of that, we have a tendency to generally treat patients who've not expressed wishes to diminish treatment or to reserve treatment or to select treatment that's more palliative in nature to treat patients more aggressively. And that physician death anxiety in terminal care plays out in many, many situations. So we have a tendency then for those doctors and clinical professionals that have a high death anxiety, we have a tendency to treat the patients more aggressively. We're less tolerant of clinical uncertainty. We, in a sense, do more care for elderly patients, less care for elderly patients, and greater interest in subspecialty medicine. We do more referrals, we do more tests, we do more procedures for those patients because we have greater anxiety related to that. And we know for sure that between a third and a half of all MDs and clinical professionals are uncomfortable talking about these issues with their patients and families. Doctors and nurses and social workers with higher personal fear of death are also less likely to disclose prognosis to patients. They are They assist in selecting a proxy decision maker, less likely, and seeking out that proxy decision maker. And they collaborate with team with advanced care planning, less likely than they would be if they have a greater sense of confidence. There's also similar discrepancies for those who are dealing with neonates and small children. So the patient and relative agreement on the patient's treatment preferences, the family is more likely to be more aggressive than the patient, as I think probably has been our lived experience for most of us, in terms of not wanting to see the patient succumb to an illness or the difficulty making those decisions. And we find that, especially in hospice and palliative care, that there's a greater acceptance in many cases where the patient, him or herself, related to his or her declining health than there is in many cases from the family members. So what are these implications related to that? There's higher risk of depression for those. This is basically patients dying of cancer and relatives of persons dying of cancer. There's a higher likelihood of major depression, generalized anxiety disorders, panic disorders. There's also been complicated grief disorders associated with the lack of readiness and willingness and appropriate interventions with families related to continuing decline of a patient's condition. And then also post-traumatic stress disorders, especially in those situations where events occur that are viewed as being regrettable after the fact. An emergency admission to ICU, a patient gets hooked up on tubes and started on a vent, and family members arrive and scratch their heads and say, what is it that we didn't see coming here? And now we're having to look at mom never wanted this or dad never wanted this, and what are we going to do to fix this problem now that we've got them on this the vent or the feeding tube or whatever, in terms of being able to make the decision, as I mentioned earlier, and being able to withdraw. In the ICU, we know that about 70% of the relatives had symptoms of anxiety related to the caregiving that they were doing, especially when they saw patients in delirium. They were 2 times as likely to have generalized anxiety. 35% of them were depressed. And there's also more anxiety when there is an acute illness and an absence of a regular physician and nursing or team meetings, both in the acute care setting and in the non-acute care settings, and a lack of room reserves for meetings with relatives. And this is primarily in the ICU setting at the time of the admission with the family. Also, about half of them reflect conflicts with the medical staff because they feel slighted in terms of the primary caregiver's role and being able to participate in treatment discussions. A lot of miscommunication, and a lot of unprofessional behavior in terms of, and not necessarily unprofessional, but moral distress issues around the mistreatment of patients, especially on the part of clinicians who are required to provide certain levels of support that they see as being of no value to the patient and only prolonging the suffering of the dying process. About half of those patients really indicated that they also valued clergy, which in some cases were not as welcomed in the acute care setting, the ICU setting, as they might be in med-surg or in other settings outside of the acute care, the ICU setting. And the families also indicated that they wanted better space, and more often, more frequent meetings, and they wanted more direct contact with the primary physician, not necessarily the subspecialist, in terms of what they were facing and questions they had related to their care. Families in the ICU where death was what actually occurred also indicated significant levels of distress, PTSD at about a 14% level and depression at about a 20% level. And the traits related to that were obviously knowing the patient for a shorter time, and then the discord, these conflicts that occur in the ICU or in the hallways of the hospital, and that, the preferences that people have related to being able to determine the patient's goals in relation to the treatment that is being offered. And usually then the defensive posture that the clinicians take in continuing aggressive treatment when there's not agreement among the family members themselves. So how much do patients really know about advance directives? And this is kind of in general in the population. Almost all of us claim to have some knowledge about advance directives, 93% of us. But only about 43% claim to have an advance directive. And what we've done is actually drill down and found out that even though 43% of people claim to have one, only about a third of them actually do. So that claim is actually a little bit higher. It may have something to do with the fact that they know who they want to appoint as their durable power of attorney, and they just haven't done it and put it in writing yet. But claiming that they had done that doesn't necessarily mean that that individual is going to be the one that is put in the situation of being able to speak on behalf of the patient. When there is no formal appointment, it ends up usually being a group of individuals, kind of moral agents, that participate in that discussion rather than an individual, which sometimes leads to the conflict among family members. About 25% of them thought they had given their copy of their advance directives to their physician. And in most of those cases, if they had, if that accurate assessment was that about 25% of them had, the physician was either not able to retrieve it or had no knowledge of it to begin with. So even though there was claims by many individuals to be able to do it, the advanced care planning documents were simply not there. And then finally, age had a lot to do with it, and advanced disease also had a lot to do with it in terms of the reading ability of patients. And we've really discovered that, especially for those that are not of the majority population, have not had access to traditional healthcare services or are affected by either cultural or language barriers in terms of being able to rely on the traditional documents that we rely on in most settings, the legal documents that we have within the states. The preferences for life-prolonging care are also related to economic hardship and emotional. So economic hardship was identified by many of the individuals as something they really wanted to avoid in their family situations. They did not want to have to put their patients, their family members through any kind of discomfort related to their passing. They also were basically saying they did not want life-prolonging treatment related to pain. Many individuals express a higher rate of concern related to life-prolonging treatment if they're, in fact, in states of distress, especially painful physical discomfort. And then finally, the older we get, the more likely we are to state that we don't want life-prolonging treatment. So those in the 70 age group are far more likely to indicate that than those in their 50, and those in their 80s and 90s are virtually in the upper echelons, the 80% and above, who are indicating that they do not want to seek life-prolonging treatment. And then the other is the treatment for depression. If we become depressed, then many people are concerned, overly concerned, about the issues of economic hardship, pain, and basically lingering and not being able to provide the kind of death that they're looking forward. We also know that religion plays a big part in this, and you might be surprised to know that in many cases it works kind of in the opposite direction. I think most of us would have this notion that individuals who have kind of a very firm conviction around heaven or an afterlife that is welcomed, they are somewhat less likely to choose palliative care than those who are less likely to have basically firm convictions around end of life. But a good half of the people report that spiritual needs need to be met, and but many of those spiritual needs in terms of existential suffering and those kinds of issues are not necessarily supported by their own religious faith community or what they've relied on traditionally in terms of a religious affiliation. So those things are important as well. And another large group of the individuals do not feel supported by the medical system in being able to explore those kind of non-faith-based, more existential issues that the families are affected. That final bullet there is that religiousness is associated with wanting all measures to extend life. was the surprising data that came out from a 2006 and 2007 study that was conducted around the fact that people, the more the religious are, not necessarily spiritual, but the more religious are, they do usually seek more aggressive treatment. So again, understanding how sick they are and their own course of illness is very important for them as they move forward. So how do we go about preparing ourselves for a more hopeful disclosure in terms of where we are going to be able to take our discussions around what we expect and what we hope for, and then matching it with what we actually get from our care providers? So this is, again, coming from a lot of good evidence that has been collected over time in multiple citations related to research, is that patients want doctors to be knowledgeable and realistic. They want an opportunity to ask their physicians questions and their care providers, not just their physicians, but also their team members. They want an offer to date their treatment and say that pain will be controlled. They want a kind of a picture of what to expect, even if it's in the theoretical, in terms of what kind of course of disease they're looking at, how long do they really kind of have to think about this, and the easier the conversation is in terms of the theoretical, the better it is for those patients, rather than talking about it in the crisis moment, but more in terms of the theoretical. So once a condition is identified that may be life-limiting, to begin that conversation early on is very helpful for patients as they gain that confidence in being able to ask questions, and the practitioners gain the confidence in being able to engage the patients and families. They also indicated that they lose hope if the doctor appears nervous or uncomfortable. They're less likely to ask questions. They're less likely to engage if the physician or the healthcare provider is avoiding the discussion or seems nervous about it or anxious about having those conversations. So it's very important for all of us to gain some confidence and skills in being able to use these tools that will hopefully be shared with you in the second half and the third half, the second part and the third part of today's presentation. They're also very uncomfortable with the use of euphemisms. I remember we participated in a study in 2008, 2009 here in Kansas City of patients involved in a focus group. And I remember a woman describing the reference that her doctor made to getting their affairs in order. This was after the death of the patient. We brought families back together to say, how did it go in the final stages of your illness, in discussions with clinical providers. And the woman was, in her description of it, used a few expletives related to the discussion that she was having with her doctor, saying that she had no idea that getting your affairs in order meant he was in the final stages of his illness, and was quite resentful of the fact that they never really were able to have that conversation with their oncologist related to how sick her husband really was. So kind of reinforcing, excuse me, through a story that the fact that euphemisms usually don't work for families. So just a few tips in terms of having those family meetings, and I know Carol and Maria will be talking more about this with you later. Making sure that you accommodate extended families, that this is not just solely the individual named agent in the cases. If there's conflict, you may be having challenges that you need to address related to that, and I'm sure Maria and Carol will be happy to answer questions if that situation kind of confounds you at times. Also, not making it overwhelming, especially in the acute care setting, that you minimize the number of staff, especially maybe the family members may number 5 to 10 or whatever, and you need them in the room, but you don't need an army of folks representing, if this is really about clarifying values and preferences and treatment options and goals of care. The other just kind of friendly family tips related to sitting down, making sure that you're not standing up and lording over the patients, taking your time, making sure that you're checking with folks to make sure that they understand, and that you provide it in a confidential private space so the family doesn't feel like this is occurring out in front of God and everybody gets to make a decision. So there's lots of questions and issues around, let's think about what we're trying to do instead of saying, do you want or do you not want? And I'm sure Carol and Maria will be talking about this in terms of how you have those goals discussions. And so I'm not going to go into this, but Obviously, addressing the abandonment fears and those kinds of issues are going to be important during the second and third hours as you listen to how it is that you actually have these discussions. Again, kind of laying the groundwork for them. They'll be focusing on goals. They'll be talking about enhancing the patient's sense of control, these fears about abandonment, those kinds of things in terms of their discussions, and assuring patients that they're being cared for in positive treatment areas. So I want to now spend a little bit of time talking with you about some of the legal issues in Kansas and Missouri related to specifics on living wills and durable powers of attorney, and then also talk a little bit about actual physician orders, which are quite different than advanced directives. So first of all, both states, Kansas and Missouri, have living will statutes. Those are the statutes that govern what we call the healthcare directive, which is the traditional, and this is longstanding since they were adopted in the 90s, kind of this language that says this is what I do and this is what I don't want. A patient does not have to have completed a living will. We do recommend and highly recommend that they appoint a durable power of attorney for healthcare, but it is not a requirement that that agent have a healthcare directive to guide them as long as they've had a good discussion with the agent. So many of the resource materials that the center provides help families to be able to have those conversations. And what we don't insist on is that people actually have completed a living will. However, for those patients that are already advanced in age or disease and are very clear about what they do and don't want, especially those that may have survived multiple episodes of life-limiting conditions and treatments and episodes, they may wish to go ahead and complete a living will. And in that case, there are statutory forms that are available to both residents of Kansas and Missouri. So the appointment of the agent obviously is another set of statutes, and both states have that. In the state of Missouri, just as an item of reference for you, that particular document does need to be notarized. In the state of Kansas, it does not need to be notarized. It can be, but it doesn't have to be. It just needs to be witnessed by 2 people. The center has documents on its website which are available to you for free. And it also has a resource document that says what are the requirements in terms of witnessing and notaries related to those 2 documents, which is available on our website, which Matthew can make available to you if you would like to download those and provide those to your families or your staff. I also want to talk a little bit about the out-of-hospital do not resuscitate law in Missouri, and then a directive law that exists in Kansas. And I'll talk about that in just a minute. But let me quickly indicate to you that there are no surrogacy laws currently on the books in either state, and that means that there is no pecking order. The states of Kansas and Missouri are, I think, 2 of the remaining 8 states in the nation that do not have those. So what is normally done when there is no agent named is that the healthcare providers are responsible for convening what we consider to be kind of moral agents around, and then using this, if there is no knowledge of what the patient wants, using the principle of best interest in working with the medical team to basically address the concerns that they have related to the treatment options that they face. There is also, in the states of Kansas and Missouri, no aid in dying, either legislative or other mechanisms. And as I think I mentioned earlier, in the Supreme Court decision, we have no right, there is no constitutional right to end our lives. So basically what the laws do is protect patients from being able or being at risk of dying by the fact of someone makes a decision to terminate their life prior to what is considered to be medically appropriate. Also, we want to make sure that everybody understands that physician orders are governed by scope of practice and standard of care, and are not usually detailed in law. So there's a lot of confusion sometimes around directives and physician orders. What your takeaway should be here is that directives are usually very clearly outlined in statute, but physician orders are usually governed by, or most in all cases, governed by scope of practice and standard of care. So those are the distinctions that are made in terms of kind of the dependence upon statutory designations related to that. I did want to provide you a little bit of information too in terms of guardianship. This is just a very cursory look. So if you have a guardian, There are certain decisions that a guardian can and cannot make in both Kansas and Missouri, and they also indicate who gets to make the final decision if there is an agent and a guardian both in relation to those. So the citation here, if you so desire, you can access, it's updated as of July 2015, indicated that in both Kansas and in Missouri, unlike Illinois, the guardian actually makes the decision if there's any disagreement between the guardian and the agent. The guardian trumps in both of those situations. And in fact, in Kansas, the guardian can actually reappoint an agent once that guardian is designated. The guardian also has limitations in terms of the decision-making authority in Kansas, in terms of them being able to make decisions related to life-sustaining treatment. In Kansas, the guardian, along with the physician, must receive agreement by the court in order for making decisions related to withholding and withdrawing of treatment. So how do you engage in this process of advanced care planning? And where do these documents get completed, and where do they get stored after they are completed? So as I mentioned earlier, the process of choosing an agent is very, very important. And we really like to encourage care providers to engage patients in conversations well in advance of any type of diagnosis or illness, in terms of being able to go through what it is that they think is most important in their lives, values and preferences, and have a conversation in choosing that agent. And for those of you that are qualified healthcare professionals and can now bill for this service under Medicare and in many third party, we encourage you to pursue those avenues in order for you to be able to have those discussions with your patients and family members, so that those agents are appointed and the process of beginning that conversation about values and preferences take place long before an acute episode happens and we're forced into a crisis situation of trying to make a decision related to what the patient does or does not want. We also want to underscore the fact that we really encourage that you choose, and everybody in your counsel to families and to patients, is that they choose an individual and maybe name a successor, a second person as a agent, as opposed to co-agents. The reason for that is that there's a kind of a moral obligation on the part of the providers to, if there is a co-agent, to get hold of both individuals. And when you have a succession and first and a secondary person, the individual, the named agent still has a fiduciary obligation to call the second person, but the provider really is relying on that individual who is named, and if the first individual is not named, they can go to the second. It makes it a little easier for them to do that. So we encourage the documents that we provide, and I think most that you'll see, that there not be co-agents related to that assignment. Also, the fiduciary obligations of the agent are again outlined in some of the material that we have, the Caring Conversation booklet that is available online, for you to be able to make sure that family members that are named, or friends that are named, understand what their duties are in terms of first following an instruction, or making sure that they're actually providing substituted judgment, not doing what they think is best for the patient, but what the patient has informed them that they want most. And so those fiduciary obligations are outlined in that material. I encourage you to make that information available to the agents, and that they not shirk that responsibility in making sure that they're speaking on behalf of the individual when they need to. And then the job of all of us is to make sure that they choose somebody that is going to be able to make the decisions for them. So not in all cases is that my oldest child or my spouse. In some cases, it may be better to choose someone who actually can make the decisions that we want made, rather than relying on somebody who's emotionally distraught at the time. So what does advanced care look like? As I mentioned earlier, we talk about it at the center in terms of kind of prevention and wellness, which is that theoretical, all adults over the age of 18 should be naming an agent, should be having conversations around their preferences and values. As they progress in their age or disease states, the issues around goals of care really become much more important, and understanding the declarant's position becomes much more critical in terms of their own awareness of their illness, and then what their goals of care are related to any kind of interventions that they're going to be facing over time. There are both legal and normative distinctions. We all have a law, the law governs the individual in terms of an appointment, and the duty of care governs all of us in terms of our responsibilities in not abandoning patients. And then we also should be guided by policies and procedures within our institutional settings. We need to make sure that those policies and procedures are up to date and accommodate new forms like the TPOPP form, which we'll be talking about in the second two segments of these sessions. And then also being familiar with scope of practice and standard of care in terms of what we as individual professionals can and cannot do. So in that advanced care planning, obviously we're going to be trying to capture the descriptions in a variety of ways, whether it's in a document. Many now are relying on audio files, and in many cases even electronic documents are being able to be downloaded and made available to families and retrievable from the cloud when these discussions take place, to provide some sense of groundedness for what the patient believes is important or not. And I encourage you to explore some of those issues. They're available online in a host of different websites, which we can provide access to you if you're interested in doing that. For those of you in settings, especially where some of the individuals do not have language competencies or proficiencies that you would like to be able to make those situations more available to them. There are a number of good websites and resource and research out there. The responsibilities all of us have to explore and confirm, making sure that we use the right questioning techniques. I think that also will be covered in the second and third segments of today's. And then advanced care planning for those living with chronic and progressive disease is really where we're going to be headed over the course of the next 2 hours. So we're going to be looking at the clinical support that's needed, trusted guidance from not only healthcare professionals, but faith leaders and others in terms of how it is that patients come to getting a better understanding of what they want, and then the role of palliative care, which both of these professionals who will be speaking after me are complete experts in and have been doing this kind of work for 20, 30 years. So in advanced illness, as we move away from the prevention and wellness activities and start moving into goals of care, there are a number of excellent tools that we have that have been given quite a bit of research that are leading us to understand the importance of asking the surprise question about whether or not the patient would be alive in 12 months, and how that question gets answered in terms of the clinical professional, and then how that leads into the transportable physician orders for patient preferences and pulsed kinds of issues. And that's when we're going to be start to really get down and dirty in terms of understanding the difference between physician order sets and advanced directives, and making sure that we're clear about that. And I assume both of you will be covering a little bit about the difference between, Maria will be? The difference between physician orders and advanced directives, and making sure that when we're relying on physician orders, those are the order sets that have been translated from the discussions with the families related to advanced care planning discussions. So the reconciliation of those goals and wishes are really what we're going to be moving into now, and kind of ask and answering the questions about what do they fear, what are they hopes for, what are the expectations, and those kinds of things as we move forward. So the reason that people don't do these kinds of things is that they think they don't need to. They'll have plenty of time later. They're too complicated in terms of the legal aspects of it, but we want to try to take away some of those barriers and being able to facilitate these conversations and normalize these conversations as we move forward. And we also know that clinicians in a 2011 study don't always follow those wishes, and the reason for us in being able to have the importance of having these conversations is for us to be able to clarify those and be able to explore where it is that the family is in terms of their own comfort related to discussions around advanced treatment, aggressive treatment, and palliative care. This is just a quick slide, and I'm not going to spend a lot of time on it in terms of claims by patients about advanced care planning documents, which you talked about earlier. There's very little evidence that people have done the full work that they need to get done, and that's, again, the importance of the reason for us for having goals of care discussions as they move further on in the course of their treatment. So the patient and outcome caregivers, I think I talked about these a little bit earlier, but again, there's more evidence that that elders do engage and they can choose, and they're more likely to be able to express their wishes if they're engaged in controlled, thoughtful conversations around advanced care planning as they prepare for the end of their life. And the importance of agents can be underscored again in terms of being able to translate for the individual back to the professional caregivers, and making sure that the rest of the family is involved in the course of understanding of how sick the loved one is and what they're going to be able to do in terms of accomplishing the goals that they may have, especially that as it relates to being able to die at home. This is just a quick summary on the stresses that agents go through. I'm not going to spend time on that. Do physicians follow the expressed wishes? Most of them say they will or they do, although there's some question about whether or not that happens when families begin to raise questions and disagree with maybe some of the treatment options that are available to them. Again, that comes from the lack of clarity and the lack of time that they've spent in preparation for these discussions. I think the scariest issue, or the most concerning issue, is that 73%, 3/4 of all doctors still report that they're making major decisions for families because there's been so much lack of preparedness. And so the importance of having these conversations is really key for us to be able to do a better job. So this next slide just kind of summarizes a little bit about how important it is to choose an agent. I talked a little bit about that earlier. If you want to use this slide in some of your specific training with agents in terms of what their responsibilities are, I would recommend that to you. And then here's a very quick picture of the differentiation between advanced care planning and medical orders, and differentiating between the two. And it's very, very important as we go through the next 2 hours for you to understand that advanced care planning are those discussions that take place with family members, and then those preferences and values and goals of care are then translated into physician order sets, which is a completely different set of documents that reflect the do's and the do not orders in terms of what the patient wants to match up with their preferences and values in terms of their treatment. So as I mentioned, advanced directives aren't enough. We need to have more participation with clinicians, especially for those with advanced illness, and most of us will be in that point at some time. And we need to differentiate between both physician orders and advanced directives as we move forward with this. And in that case, we need to be able to make it very clear to the folks when we're talking about a physician order set and when we're talking about advanced directives and how those goals and preferences will be translated. So the bridge between this wellness and prevention piece and advanced care planning over to the actual establishment of medical orders that reflect patient wishes is really where the TPOPP program comes into play. So the physician order set is really kind of the bridge. This discussion around serious illness in care planning are really how we're going to move patients from their original advanced care planning discussions into treatment orders that are then reflected by how it is that they're talking about their illness, what do they understand about how sick they are, their caregiver anxieties, the patient satisfaction that they have related to their goals of care and their treatment, in terms of making sure that we're matching up what they want with what they're going to get. And just a quick overview, the TPOPP program is a pulse paradigm program. It's been active in Kansas and Missouri since 2009. The original one started in 1991. It's basically a way for us to make sure that we're doing treatment preferences that get transferred into medical order sets, and there's an increasing body of research on its effectiveness. So with that, I'll conclude my remarks, and if there are any questions, Matthew, you can alert us to that, and we'll prepare for the next session, which will be Dr. Carol Buller on having these conversations in the non-acute setting.
Yep, we've got one question here from Cheryl, and it says, after the doctors initiate the conversation, who exactly is qualified to continue the conversation in the advanced care planning documents? And then what is considered a specialty nurse under QHCP? Okay,
if you'll get access to the first series that we did on November 17th, I believe that question is answered. Just quickly though, for the benefit, if you've not had a chance to view that session, the qualified healthcare professionals in the new regulations are physicians, advanced practice nurses, which includes nurse practitioners and clinical nurse specialists, and then PAs, physician assistants. Those are the qualified healthcare professionals. That does not mean that other team members cannot participate in preparing the document. Chaplains, social workers, and other individuals who are on a palliative care team or participating in a clinical setting with that patient can prepare and introduce and cultivate the discussion, but the only persons who can actually bill for the service are the QHCPs, which I mentioned. And there's more information on that, again, on the November 17th video that's available on YouTube. Okay? All right, so we are about ready. We'll take a quick break, a couple minutes, and we'll be back with Module 2. Thank you.